All right, let's go ahead and get started. We have a fair amount to cover today. How are you guys doing on sodium?
Tired.
Tired?
Really tired.
2 weeks for renal. Yeah. Well, I have a couple cases, like I mentioned yesterday, after we talk about hypernatremia. I think that should help you guys. Then we're going to cover potassium. There's not a lot on potassium. I think potassium is relatively straightforward as far as treatment of potassium disorders. And then we'll touch a little bit on hypophosphatemia. All right. So let's get it going. So hypernatremia is a sodium level, serum sodium level of greater than 145. This is a true hyperosmolar state. So patients should have a osmolality, a serum osmolality of greater than 297. You guys should be familiar with that serum osmolality equation that is listed in the pre-lecture. Please know that. It's very common, hypernatremia is very common in patients who have the inability to obtain water. So what kind of population would that be? Elderly?
And infants.
Infants, right? And what else?
Neurological disorders. People with
Neurologic disorders, good. Excellent. And then one other population.
disease states like
Possibly. I would say hospitalized patients who can't ambulate and obtain their own water, right? So maybe in the ICU, it's very common in the ICU population. And I would say it's a poor sign of adequate maintenance fluid in those patients. So basically your thirst mechanism is very strong, right? If you're thirsty, soon you'll obtain some water and you should not develop hypernatremia. So I would say that's the most common cause, especially in the hospitalized patient, is some patient who just can't get access to water for whatever reason. Maybe they broke their leg, they can't get out, and the nurse isn't coming over, or maybe they're in the ICU and they can't leave the bed, of course. Water output is greater than water intake. So they're eliminating water more so than they're taking water. It is associated with increased hospital mortality. So sodium level of greater than 160 has a fair amount of mortality, so 75% mortality. This is probably related to the population that gets it in the hospital. Again, ICU type patient, et cetera, maybe elderly or neurologic impaired patient in the hospital. So similar to hyponatremia, we have to assess the patient's volume status. So hypovolemic hypernatremia, there's a significant loss of water in these patients. The two biggest causes would be like osmotic diuresis from glucose, so maybe from DKA, patients in DKA, and they have a fair amount of urine output, and osmotic diarrhea. So if you remember osmotic diuresis or osmotic diarrhea, you should be in good shape here as far as causes. Another cause would be diuretic use, loss of water through the use of chronic diuretics. That's fairly common as well. The clinical presentation, the patient may have hypovolemia, of course, right, with or without a low ECV. So they can be intracellularly depleted, interstitially depleted, and their intravascular volume may be low or normal-ish. With osmotic diuresis, they can have a lot of urine output, so greater than 3 liters per day of urine. Treatment. The biggest thing with hypernatremia is it's all fluid treatment. So with hypovolemic, you have to assess to see if they have decreased intravascular volume. If they do, we give them saline, right? We want to replenish that intravascular volume and to maintain good perfusion. Once you do that, then you would transition to something like D5W. If their intravascular volume is okay and they're perfusing their vital organs okay, then you go straight to D5W. But we would calculate a water deficit. So we're going to spend some time on this water deficit equation, and then I have a case, like I mentioned, down the road. So euvolemic hypernatremia, this is many different causes. One of the causes would be ADH deficiency, antidiuretic hormone deficiency. So either the patient's kidneys do not respond to ADH, or there's an overall lack of ADH secretion from the pituitary. There's 2 main kind of categories: ADH resistance, which would be hereditary, renal disease, some drugs like lithium, dimethylcycline, amphotericin, and the Vaptams can cause that. And then overall ADH deficiency, that could be hereditary as well, or it could be due to some insult in the brain. So malignancy, head trauma, etc. Clinical presentation, these patients are euvolemic, so their extracellular fluid should be fine, but these patients also have excessive urine output. Because of that deficiency of antidiuretic hormone. That should kind of make sense. So their urine output is super high. Treatment for ADH deficiency, again, calculate that water deficit and then give appropriate fluids. So fairly easy as far as acute treatment. For resistance, you can use thiazide diuretics to decrease the plasma volume and activate the RAS system to reabsorb water and sodium. But initially, you would still do the water deficit and give fluids. If ADH deficiency, you can try desmopressin. That's probably the most commonly used agent. And there's different forms that you can use there. Orally, it's poorly absorbed, so you can use intranasal and some IV formulations. If it's drug-induced, of course, you stop the drug, right? Diabetes insipidus. This is a disorder where the kidneys excrete a large volume of urine. It's a very dilute urine based on the urinalysis. And this leads to very significant thirst. There's 2 categories of diabetes insipidus, one central related and one related to the kidney itself. The central related would be, again, any type of injury to the brain that can cause it, head injury, tumors, infection in the brain can cause diabetes insipidus. Nephrogenic would occur in the kidney based on the name, right? So that can happen as well. But the central DI is fairly common in the neuro patient. So how do you treat that? Desmopressin is the agent to use for diabetes insipidus. Again, it comes intranasally, PO, IV, sub-Q, or sublingual strip. You have the best response with the intranasal route or sublingual route. The oral route is, again, very poorly absorbed. You would dose adjust this to a urine output that's more closer to normal. So around 1.5 to 2 liters a day as far as the urine output. And then there's some contraindications, specifically renal dysfunction with a creatinine clearance of less than 50. You can actually cause hyponatremia with desmopressin. That should make sense. So if it's used at a higher dose or more chronically, you have to be aware of that and then maybe reduce the dose. Hypervolemic hypernatremia. This is fairly rare. And I would say the main causes would be iatrogenic, so administration of like hypertonic saline or sodium bicarbonate solutions in the hospitalized patient. Sodium bicarbonate has a fair amount of sodium in it, of course. Maybe salt tablets can cause hypernatremia. And then concentrated enteral tube feedings, and this is mainly because of the amount of sodium versus water. But overall, very rare. Treatment would be mainly IV D5W and then a loop diuretic to get rid of volume and sodium over time. Chronic dietary salt restriction. So the treatment of hypernatremia, I mentioned that, and you saw this, like you want to calculate that water deficit. So the water deficit is the patient's ideal total body water, which is what's the equation for total body water in a normal adult?
Depends, female.
Depends on male or female?
Male times body weight.
Okay, so 0.6 times the body weight in kilos for male, and then 0.5 times the body weight in kilos. Excellent. So it's the ideal body weight minus the current total body weight. Okay, that is the water deficit, and we'll go through this equation. So once you calculate the water deficit, you have a number that's usually in liters that the patient may be down. It's a deficit. So then you have to determine the rate that you want to correct it. This is a rate of the sodium change. So we're talking about hypernatremia. So of course you want to bring the sodium down lower, right? So if you want to go down 0.5 milliequivalents per hour or 1.5 to 2 milliequivalents per hour. And how do you decide on the rate of change?
Depending on
I think you said it. Acute or chronic, right? So which one would you want to adjust faster? Acute hypernatremia or chronic? Acute. Awesome. Remember, the rate of change of the sodium, whether it's high hypernatremia or hyponatremia, you want to, so if it's a fast change, then you can treat it a little bit faster as well. If it's chronic over months, then you want to be a little bit more careful as far as treating it fast or reversing it back to normal. And what's our guidelines as far as goals of the change in sodium? What's the number? 10 per in 24 hours. So 8 to 10 in 24 hours, right? You don't want to go more than that. So if the patient presents with a sodium level 160 today, tomorrow they should not be any lower than 150, which is still high, but you want to go slow to prevent any type of serious effects. Okay, so remember those thresholds and goals of therapy. So once you identify whether it's acute or chronic, then you have to say, okay, how do I pick the fluid? Like, which fluid am I going to pick? And it kind of depends on certainly the reason why they have hypernatremia. Depends on the patient whether they could drink water. Some of these patients, you can use regular tap water to treat their hypernatremia. So if they could drink tap water and they're not that symptomatic, I would go the NRL route. So you can, actually order tap water. If they can't drink tap water, then you're going to have to use some IV fluid. So our choices are D5W, which is, probably one of the more common choices, I would say. Sodium chloride, if the patient is hypovolemic and you want to increase the intravascular volume, or some lower amount of sodium, like half normal or quarter normal saline, sodium chloride. So you could do that, and based on the amount of sodium in the solution, you can calculate how much 1 liter of that solution will change the level of sodium. Okay? Does that make sense? So you have a fixed solution like 0.9% sodium chloride. Does anyone know how much sodium is in that liter bag? 9 grams. I don't know what grams are. So in milliequivalents, how many milliequivalents of sodium is in that liter bag? It's 154. So 154 milliequivalents of sodium in the 0.9%. So if you do like quarter normal, half normal would be half that amount, so around 77 milliequivalents. So basically, you can look at that bag, that solution, or look it up on the internet and figure out how much sodium is in that solution that you're giving the patient. And then you can calculate, okay, if I give a liter of this solution, how much will the sodium change? Now, how much sodium is in D5W? 0. Good. So 0. So keep that in mind, okay? And we're going to use that in our example. So first, calculate water deficit, determine the rate of change in the sodium that you want it to be, and that will dictate, based on your clinical presentation, acute or chronic, of course, and then determine the fluid. So this is a water deficit equation here. It's total body weight times the serum sodium, so whatever the patient presents with. So if it's like 155 over normal, and we just use 140 for normal. It's like right in the middle, right? And then -1. So that would be the water deficit. And then you determine the rate based on clinical presentation. And then again, determine the type of fluid. So let's do an exercise here. So calculate the free water deficit for a 66-year-old male with a body weight of 70 kilos and a serum sodium concentration of 154. So using this formula here, what is the water deficit? What do you guys get?
4.2 liters.
4.2 liters. Remember, that's liters. That's a lot of fluid, right? I mean, that's a ton of fluid. The patient presents with 154, normal is 140, and they have a water deficit of 4 liters. That's a ton of volume. That's right. It's 4.2 liters. So then we have to calculate the percent change in serum sodium if you give 1 liter of D5W. I picked D5W just because that's the most common solution that you're going to use. So the change in sodium equals the sodium that's infused minus the serum sodium over the total body weight plus 1. So serum sodium is what? 154. And the sodium infused is what? 0. This is going to give you a number that if you administer 1 liter of D5W, that will be the change of sodium from 154 to whatever number you get. What number did you get for the second one?
Negative 3.86.
Negative 3.6. So if you give 1 liter of D5W, the sodium is going to go from 154 and decrease 3.6 units. Okay, just from 1 liter. Now, how much D5W will be required to reduce the sodium level to 146? And why did I pick 146? You could pick any number, but why did I pick 146?
I don't want to go more than 10 in 24 hours.
Right.
It's within the max.
Yeah. So I was a little bit conservative and just picked the 8 change, right? So how would you do this equation?
3 liters.
So you know how much 1 liter is going to change it.
So 1 liter changes 3.6. How many liters will change it?
Yep. What'd you get?
2.2 liters.
So 2.2 liters. So you just set up a ratio and solve for x. So you know that 1 liter will change it 3.6, and if you want to change it 8, and then just solve for x, and you get 2.2 liters. Does that make sense? Are you sure?
The equation for the serum change of sodium concentration, if we go to the question like 0.5 liters and not 1 liter, how do we put it in the equation?
I'm not going to write that question. So what I'm going to write is something like that. And I'm going to ask you, what's the free water deficit? And then how much do you want to give over a certain period of time?
So you will give 2.2 liters over 24 hours.
Great question. How do you give the 2.2 liters? So yeah. So remember, our threshold is 8 milliequivalents over 24 hours. So based on our math, I would give 2.2 liters over 24 hours. Now, is this like definitive? You give this fluid to a patient. Is it going to change it 8 milliequivalents in 24 hours? Is this 100% accurate? No, not at all, right? It's just a guesstimate, estimate. So what are you going to do in the meantime? You're going to start this D5W at a rate, and then what do you want to do?
Check lab values.
Monitor sodium, serum sodium levels, okay? Monitor 2 to 4 hours. Make sure it's not falling too fast. Maybe something else is going on, and you aren't predicting the change as accurately as possible. So it's just estimate on how much fluid to give. Every patient is different, so the most important thing is monitoring that patient by serum sodium levels. So I want you guys to know this free water deficit equation. You're going to see it soon, meaning Monday and Wednesday. And go through some of these examples on your own and play with the numbers. Okay? It's a very common equation. You'll see it on your APPES rotation if you do inpatient rotation. I guarantee you it's going to come up. So very common. So similar to hyponatremia, the pathway is here. But remember, with hypernatremia, it's very simple. You want to give fluid back for the most part. So almost all these pathways, you're given fluid. And the other thing you have to think of is assess the intravascular volume, okay? If they're hypovolemic, you would replenish the intravascular volume before you give any other fluid. Take-home points. Remember that water moves freely throughout all three components in our body, compartments in our body. Water imbalance in those compartments leads to sodium imbalance. So water and sodium are intertwined, right? That's why we spend a lot of time on fluid. Sodium imbalance leads to volume shifts because of the osmolality, and it's the main component. Sodium is the main component of osmolality, right? Based on that equation. So you should know how to calculate the osmolality. To identify a sodium disorder, you must first assess the serum sodium. That's like, duh. Of course, you're going to look at the serum sodium. Treatment of sodium disorders is as much about fluid, right? They can be hypervolemic, euvolemic, or hypovolemic. So that is an important step to assess for that. And they must be carefully monitored in order not to cause a neurologic complication. So with both of the natremias, so hypo or hyper, if you reverse it too fast, you're going to cause more harm than good. Any questions? Well, let's go through this case. 72-year-old patient with acute disorientation presents to the ED emergency room. She also has had recent lethargy and a headache. She has a past medical history of coronary artery disease, congestive heart failure, and type 2 diabetes. Her BNP is elevated and has had recent weight gain. Her home meds include hydrochlorothiazide, metformin, and lisinopril. Her laboratory data is below. So serum sodium of 120, potassium of 3.6, chloride of 100, bicarb of 24, BUN 10, creatinine of 0.8, and glucose of 144. What are the abnormalities on the laboratory report? Sodium. What's that other one? Hyponatremia? Excellent. Any others?
Glucose is elevated.
Glucose is a little bit elevated. That's pretty much it. What are the signs and symptoms of the hyponatremia?
Disorientation.
Disorientation.
Coma, seizures.
The patient signs and symptoms.
Okay. Lethargy.
Lethargy.
Headache.
Headache. Awesome. Is it acute or chronic?
Acute.
Says it right there. I gave it to you, right? Acute disorientation, lethargy, and headache. Okay, so know the signs and symptoms of these electrolyte disorders. For sodium, you always want to think about the brain, right? What are the potential causes of the abnormalities? Meds? Thiazide. It's a very common cause, especially in the elderly. It's more associated with chronic hyponatremia, though, not acute. So she also has heart failure. And what else is going on with her heart failure? BNP elevated and
Weight gain.
weight gain, recent weight gain, okay? So this fits nice, right? From cardiovascular to here. So congestive heart failure. So we have acute hyponatremia. She has symptoms with acute disorientation, lethargy, headache. Her BNP is elevated and she has recent weight gain. Past medical history for this, more significant with congestive heart failure. She's on these meds, and I would say hydrochlorothiazide sticks out as a potential confounding cause of her hyponatremia. What's a likely classification? How would you classify this patient's hyponatremia? Hypervolemic. Hyper. So based on the case, what I gave you with the weight gain, the congestive heart failure, et cetera, I think you would classify it as, or should classify it as hypervolemic. Okay?
Is hypervolemic because of the edema?
Right. Weight gain. The weight gain.
Yeah.
All right. So now the patient suddenly becomes unconscious. So she's not in a good shape here. So what is the treatment for acute hyponatremia?
Sodium.
Loop diuretic.
I'm hearing a bunch of things. So who's going for diuretics?
Stopping the thiazide.
Stopping?
The thiazide, yeah.
Okay, stop the drug.
Yeah.
I love that. You got to stop the offending agent, right? Not you didn't say give a loop diuretic, did you?
Probably not. Probably not.
Okay, so we're going to stop the hydrochlorothiazide. What else are we going to do?
Sodium 0.9%, normal saline.
So I have 1 for 0.9% sodium. How many of you want to give normal saline? One person. All right, what's another alternative?
Half normal, 3%.
Half normal? Would you give half normal? Okay, so for acute hyponatremia, what's the threshold to urgently treat this patient? Not the sodium threshold, the patient presentation threshold. Like what are some characteristics that the patient may have where you're like, I need to treat this patient right now?
Unconsciousness.
Unconsciousness. Seizures. Coma. Arrest would be certainly anything life-threatening, okay? Think of life-threatening things. So if the patient is seizing, that's not good. That's not really compatible with long-term life. If the patient's in a coma, that's not good. So in those cases, she's unconscious, what are you going to give her?
Sodium.
Hypertonic.
Yeah.
Hypertonic saline. Remember that, okay? So the sodium level's low,
Oh, sorry.
the patient's in bad shape, they have a life-threatening condition, you're going to give them hypertonic saline. That's probably the only indication for hypertonic saline. Otherwise, you'd go somewhere else. So stop the hydrochlorothiazide, assess the volume status. We already said it's hypervolemic, and then hypertonic saline. Okay, it's for acute symptomatic hyponatremia. You're going to give 3% sodium hypertonic saline bolus, 100 mil over 10 minutes. Reassess the patient. If they need more, you're going to give it up to 3 times. You want to keep in mind your thresholds for sodium, the change of sodium, so remember those, and then adjust based on symptoms and serial labs.
So, Prof, the threshold for sodium is whether you are increasing or decreasing, you don't want to go beyond 8 or 10.
Yes, yeah,
Whether increasing or decreasing.
right. Yep, it's a general guideline. Okay? Does this make sense? So you kind of want to know, like, do I need to acutely treat this patient with hypertonic saline or not? So what are the indications for hypertonic saline?
Seizures.
Unconsciousness.
Unconsciousness. Yeah. Okay? So if I give you a case that the patient's in a life-threatening event, seizing, coma, unconsciousness, that should give you a key, like, okay, I'm going to pick hypertonic saline. And then you need to know the dose. So know this dose. AA is a 45-year-old male, 5'9", 75 kilos, admitted to medical intensive care unit for respiratory failure due to pneumonia. He is intubated, has new onset irritability and agitation. Laboratory data is there. So what are the abnormalities on the laboratory report? Sodium, glucose, hyperglycemia. BUN's a little bit elevated, right? 18. Chloride is elevated as well. But the main thing that we're going to talk about is sodium, of course. So 155. Oops. What are the signs and symptoms of the abnormality?
Irritability, agitation.
Again, sodium, think CNS effects, right? Irritability, agitation. What are the potential causes of the abnormalities? So he is in the ICU and he has respiratory failure. So he's probably intubated from his respiratory failure. So what's the cause? Could be medication.
Maybe they give them too much fluids.
Maybe they give too much fluid. That could be. What's another potential reason? I'm sorry, I didn't hear that one. Dehydration? From what? Awesome. So this guy can't leave his bed, right? He doesn't have access to water. Who gives him his water? We do, medical personnel. So he has no access to water. Okay? So he's admitted to the medical ICU. He's intubated, irritability, agitation. So another one we didn't talk about would be insensible water loss. If he had a fever, I didn't tell you he had a fever, but if he had a fever, you can lose a fair amount of water if you're febrile. He's on mechanical ventilation. You can certainly lose a lot of fluid through your respiration, right? And certainly on the mechanical ventilator, you lose more fluid than normal. But it's probably more likely due to inadequate free water intake. So he has no access to water. He can't obtain water by himself. It could also be due to critical illness fluid-related shifts, but probably less likely. Okay, so we have a sodium level of what? 155. How do we treat this? Fluid. You want to give half normal? You can give half normal. First, you want to calculate the water deficit, right? So someone, or all of you calculated his water deficit, and he's male, even though I made a mistake. So calculate it as a male. What did you get? I forgot to change that up there. Calculate it as a male. So you should have got 4 something liters.
4.8.
4.8.
Oh, yeah.
5 liters.
Okay. I got 4. Oh, I did it's probably 4.8. I used a female. That's why. Okay. So 4 liters, 4.8 liters, depending on the gender. Okay. And then predict the change in sodium. So again, if you give D5W, 1 liter D5W, change in sodium would be about 4. And then how much D5W would be required to change the sodium level to 145. So that's a 10 unit decrease in the sodium. Here, if I did the calculation right, it would be 2.5 liters. And then you administer that over 24 hours. Did someone double check my math? So you certainly will have to do the pre-water deficit. And then you have to come up with some idea of how acutely to treat it. So again, if it's acute disorder, you want to be a little bit more aggressive. If it's a chronic disorder, you want to go a little bit slower, okay? So the rate of change. So remember that rate of change. for hypernatremia. Any questions about treatment of hypernatremia and the calculation of water deficit? All right, so kind of go through these steps when you're assessing someone's sodium level. First, look at the serum sodium to determine whether it's hypernatremia or hyponatremia. Assess for symptoms and really kind of fine tune on those neurologic symptoms with sodium disorders. Assess for the rate of development based on the history that you have in the case or the patient presents. So if it's acute, less than 48 hours, treat it as such. If it's occurs over more chronically over greater than 2 days, then treat it as such. You want to assess the effective circulating volume, check the patient's blood pressure, of course, and have some general assessment of plasma volume. And then determine the patient's volume status, hypovolemic, euvolemic, or hypervolemic. Once you have all that, you should be going down those pathways, okay? If you can determine the underlying cause, that would be awesome, especially if it's a drug cause, because then we should stop that drug, right? That's sodium. Let's start potassium. How many of you all looked at the pre-lecture potassium material? Couple. Please review it, even though you didn't have a quiz. It will help.
Dr. Gonzalez,
Yep.
the pre-class is something for us, not for the test, right?
Oh, you're tested on it. Yes. All the pre-lecture stuff is fair game on the test.
Is inside the test also?
Any test, the case application, the exam on Wednesday, it's all fair game.
Sodium in brain.
Okay. Okay, so hypokalemia, treatment of hypokalemia, the goals would be to prevent and treat life-threatening consequences of hypokalemia, so low potassium, okay? You also want to identify hypomag and treat that concomitantly with administering potassium. Remember, Dr. Joshi mentioned the sodium-potassium pump, right? And one of the cofactors of that pump is magnesium. You need magnesium for that pump to work at its best. So if the patient is hypomag, you need to replenish the magnesium in addition to the potassium. You want to identify and correct any underlying causes. What are some medication causes of hypokalemia? What's one common diuretics? All right. What specific kind of diuretic would cause more hypokalemia than others?
The non-sparing.
Loop diuretic. Furosemide. Normalize potassium and avoid overcorrection, okay? So you kind of want to target the middle ground of potassium at 4, and probably not much higher than that. You want to be careful with potassium in patients with CKD because your kidneys are responsible for elimination of potassium, right? So if they have any type of renal insufficiency, even if they present with hypokalemia, what you give, it's going to be hard to take back if you overshoot it. So be very conservative in those patients. So CKD or acute kidney injury, so acute. Here's a couple different ways you can estimate their potassium deficit. So one is to look at the normal potassium, which is 4, minus their patient's current potassium and times it by 100. That should give you a deficit. So 4 minus 3, let's say the patient comes in with a potassium of 3, that is 1 times 100. So the patient has 100 milliequivalents of potassium deficit. Does that make sense? This is a rough estimate, okay? I wouldn't give 100 milliequivalents to someone with AKI or any kind of kidney disease, but it will give you a baseline to start from. You can use this deficit for either PO or IV repletion. And PO and IV is, as far as absorption, it's 1-to-1. So there's no absorption issues with potassium. Alternatively, you can use this here. So if the potassium is from 3 to 3.5, 10 milliequivalents of potassium is required for every 0.1 increase in potassium. So if the potassium is 3.5, the patient's potassium is 3.5, you want to get them to 4, that's going to be about 50 milliequivalents, right? If the potassium is less than 3, so let's say they come in at 2.5, so it's 20 milliequivalents for every 1.1 milliequivalent increase. This is a little bit controversial on that, but either one would be appropriate. Either one would give you some sense of baseline to start with. So just like sodium, you're going to start with an estimate, give the potassium, and then reassess this patient's serum potassium, right? Maximum PO dose of potassium should not exceed 40 milliequivalents per dose. At above 40 milliequivalents per dose, you start seeing more adverse effects with potassium. Those would be mainly GI adverse effects and possibly delayed absorption. Maximum IV dose of potassium should not exceed 10 to 20 milliequivalents per hour. If you go above that, you can start seeing more cardiovascular adverse effects of potassium. And then certainly be cautious in patients with renal impairment. There are many different anions formulated with potassium. The most common is potassium chloride, so both oral and IV. That's probably the one that you're going to run into the most, but there's potassium bicarbonate, potassium citrate, and potassium phosphate. If the patient has hypophosphatemia and a low potassium, you can certainly choose potassium phosphate and correct both. Oral potassium comes in tablets or a powdered solution. So if the patient can't swallow the pills, you can always give a powdered solution. The patient is You can use this if the patient is mildly depleted and asymptomatic. I mentioned the adverse drug effects there, and those are dose limiting. And then remember for magnesium, you want to check it before you replace a large amount of potassium. IV administration is only used in hospitalized patients, more typically with the potassium level less than 3. So they have a fair amount of deficit, and patients who cannot tolerate oral for whatever reason. Also used if the patient has any EKG changes with hypokalemia. Okay, so if they're already showing EKG changes associated with hypokalemia, then you would go towards IV potassium. It's a very high risk medication, so there's been a lot of errors with IV potassium leading to complications and even death. So you want to be careful with it, certainly with the dose and how fast you give it. That's why there's a lot of safety thresholds there. As far as IV potassium, KCl is the most commonly formulation used. You can also have potassium phosphate as an IV formulation as well. It can be administered peripherally or centrally. So peripheral would be maybe in the arm or the hand, an IV catheter, or if they have a central catheter, you can administer it there as well. It can be an irritant and a vesicant, so you have to be aware of how much you're given peripheral versus central. For peripheral, 10 milliequivalents can be infused over an hour and then repeat every hour. For central, you can do a little bit higher doses, 20 to 60 milliequivalents, but the rate should be 10 to 20 milliequivalents per hour. And then for central administration, you should have the patient hooked up to cardiac monitoring. With severe hypokalemia, so severe would be less than 2.5 milliequivalents per liter. You have 10 to 40 milliequivalents per hour with a max rate of 40 milliequivalents per hour via the central line. So you definitely want to measure the serum potassium frequently throughout therapy, monitor the patient's heart rate and EKG, especially if given through the IV route, check the magnesium level, and then common patient complaints with IV would be pain on infusion. So if the patient experiences that, you can slow the rate of delivery, and that might help, and GI upset with oral formulation. Those would be the most common patient complaints. Be extremely careful in kidney disease, okay? Because it's easy to overdo it and give too much potassium. Any questions about hypokalemia? Pretty straightforward. So know the deficit. Either one of those would be fine. Hyperkalemia, if it's a medical emergency, meaning a potassium level is greater than 6.5, the patient has symptoms or EKG changes. So there's certain EKG changes associated with hyperkalemia. They're listed in the pre-lecture slides. Make sure you know of those. So if you have any of those, and I would say it's severe symptoms, then you want to go through the step approach. So step one would be to protect the heart. And I think Dr. Joshi mentioned this as well. You want to stabilize that cardiac membrane. What did she say to give to stabilize the cardiac membrane? Remember, she put the action potential up there, and she's talking about you can stabilize the cardiac membrane. May have gone past you, but you give calcium to stabilize the cardiac membrane, okay? So step one, and this is only emergency. Step one, protect the heart. So stabilize the cardiac membrane with calcium. Step 1.5, stop any excess potassium intake. So always double check to make sure there's no potassium going into your patient, right? It could be an IV, it could be tube feeds, it could be a TPN. Always double check, because I've seen it time and time again where they just continue the potassium and you're trying to treat hyperkalemia. So stop the potassium. Step two, rapidly lower extracellular potassium by shifting the potassium into the cell. So remember, Dr. Joshi talked about the redistribution based on the sodium potassium pump, and you're trying to push the extracellular potassium inside the cell. So we want to do that with step two, okay?
And what did you put on 1.5? Once you stop this, this is going to occur naturally? Is that why you put like step 1.5?
What do you mean natural?